Welcome to the Bioethics Babe podcast, where we examine the tough questions in human flourishing in light of science, faith, and culture. I'm your host, Arina Grossu Agnew. Now let's dive in. Today's guest is Dr. Patrick Lappert, a twice board-certified plastic and reconstructive surgeon who has spent more than 30 years in the operating room and 24 years serving our country in the United States Navy. Dr. Lappert was Chief of Plastic and Reconstructive Surgery at Portsmouth Naval Hospital and the Reconstructive Surgery Specialty Leader for the U.S. Navy Surgeon General. He founded the Pediatric Craniofacial Unit and the Wound Care Center at the largest military hospital in the world, and retired with the rank of captain before continuing another 18 years in private surgical practice. He has served as an expert witness in state and federal cases involving surgical interventions on people with sexual identity disorder, contributed to legislation protecting minors, and authored chapters on combat injuries, the scientific evidence against surgical interventions on people with sexual identity disorder, and the pastoral care of those harmed by the transgender industry. While on active duty, Dr. Lappert served with the U.S. Marine Corps for 3 years, flying in the F-4 Phantom with Marine Fighter Attack Squadron 451. Today, he serves as a deacon in the Catholic Church. He and his wife, Patrice, have been married for 44 years, raised 6 children, and have 2 grandchildren. Welcome, Dr. Lappert.
Thank you very much.
Thank you for being on. We are so thankful that you are here to share with us your expertise on this very important topic. When did you become interested in medicine, and particularly in becoming a plastic and reconstructive surgeon? And was there a particular experience that led you to this line of work?
Well, that's a challenging question. I think even when I was a young boy, I kind of had a sense of myself as a doctor. And I remember my grandmother sort of encouraging me to sort of think along those lines, but I put it aside for many, many years. I was away from school for a number of years as well. But then while I was away, it occurred to me that I really should go back to school with the intention of becoming a doctor. Now, I didn't imagine myself a plastic surgeon when I first set about going back to school. I thought I was going to be a psychiatrist of all things. But in the course of study and my growing interest in physiology, and I was more attracted to internal medicine, and then that led me into general surgery. And then while I was serving with the Marine Corps, I wanted a very independent life as a physician, as a surgeon, and I thought plastic surgery would be excellent. And the more I looked into it, the more I realized that the specialty of plastic surgery involves really the whole of humanity, from infants to the elderly, from trauma to cancer care to congenital deformities. What people sort of humorously say is that plastic surgery is surgery of the skin and its contents. So basically, it's the entirety of the human person, and I really like that. And the fact that you can live an independent life was very attractive to me. So.
Mm-hmm. And you have a very unique career path from military medicine to plastic surgery. What ties all of these chapters together for you?
Well, when I was training as a surgeon in the Navy, I was drawn to the trauma care as a general surgeon, and then the reconstruction of that was the reason the Navy sent me off for additional training. The military needs reconstructive surgeons. In fact, of all the surgical specialties, plastic and reconstructive surgery is the most broadly applicable to combat injuries and the like. So the Navy sent me off for plastic surgery training at a civilian institution, and then I served as a plastic reconstructive surgeon for about 8 years before retiring out of the Navy. So.
Mm-hmm. And how did your experiences as a reconstructive surgeon in the Navy shape the way you think about the human body, healing, and surgical responsibility as well?
Well, one of the things that I was very much drawn to is the care of the wounded, and in particular the care of the chronic wounds that just don't seem to heal. And that's when I established and developed that wound care center at the Portsmouth Naval Hospital. So I've always been drawn to that part of it, and the idea of the wounded person. That encompasses so much. What I think is at the heart of my life as a physician is the care of the wounded, whether they're wounded spiritually or physically. It's all of a piece because of the nature of the human person, our single nature. So one of the things that the care of my chronically wounded people taught me is that there's great grace that comes into the relationship between the wounded person and the physician. And the thing that wounded people need more than anything is the presence of the physician, the commitment of the physician, the willingness of the physician, that it isn't all just a bunch of technical exercises and technical procedures and the application of advanced medications and things like that. The willing presence of the physician who is willing to share in the suffering of the person. That's probably the most important thing, and the thing that I love the most about being a surgeon.
That's so beautiful, and especially with your role as a surgeon and as a deacon as well. You do handle both the physical and the spiritual aspects of a human person. So, what is the difference between reconstructive surgery and cosmetic surgery? I think a lot of people, when they think of a plastic surgeon, they probably most more often think about someone who does cosmetic surgery.
Yeah, that's definitely the case in our times, that when you speak of plastic surgeons, people immediately think of cosmetic surgery. And Arina, this is a very important distinction that we have to make in the discussion that we're going to have today, that the distinction is critical for understanding the issue. So reconstructive surgery is surgery that's done in an effort to reconstruct or to restore form and function that has been injured or lost due to accident, due to surgical care of cancer, congenital accidents in utero, whatever the cause, it's the restoration of form and function. So it begins with a defined poverty that the patient presents with. There's a loss that you can measure, you can characterize the type of tissue that's been lost, the location. Very important to characterize the functional losses. So form and function together can be defined, and this is what determines the nature of the surgery that you plan, and the direction in which you counsel the patient as far as what they're going to expect. So, for example, a hand injury, we can define loss of a finger, we can define loss of soft tissue, loss of range of motion or strength. Those can all be defined preoperatively. And then the result, the outcome of the surgery, can also be likewise measured postoperatively, and you can characterize the success or failure on those same grounds. So this is to be contrasted with cosmetic surgery. Cosmetic surgery begins, actually, let me step back. Cosmetic surgery, or what I prefer to use the term aesthetic surgery. Okay, aesthetic surgery, because cosmetic surgery suggests that it's all about vanity, but aesthetics places it rightly in the human experience, because the beauty of a thing is a very important aspect of the human condition, right? So you can have aesthetic issues that have a subjective effect on the patient. In fact, that's what aesthetic means, is that what you see or what you hear or whatever has an effect on the way you feel. So the motivation for aesthetic surgery or cosmetic surgery begins in the subjective life of the patient. They see something that affects them daily, that they deal with daily. So a common one that I experienced in my professional life is the person presenting and saying, I work as a bank teller, and I feel great, and my life is great, but at least once a day, somebody will ask me if I'm getting enough rest. And so they're dealing with this annoyance, and they look at themselves in the mirror and they go, gosh, I really do look tired. And so you can do an aesthetic procedure, right? The appearance affects the subjective life of the person, but you can do a procedure that modifies that in a way that resolves the issue completely. So, a little freshening up of the face, the eyelids, very commonly, or the position of the brows, is what makes people look tired. So I can solve that problem, and it changes the life of the patient in an important way. Their subjective life, their aesthetic life is improved. So the point is, aesthetic surgery begins in the subjective life of the patient, and the success or failure of it resides in the subjective improvement of the patient, right? There isn't something measured. There isn't some strength or range of motion or any integrity issue. It's strictly in the subjective life of the patient. That's a very important distinction, because it also affects what we can ethically offer to the patient, what is beyond the bounds of what that surgery intends.
Mhm. Right, and obviously with reconstructive surgery, as you mentioned, it's rebuilding something that was that was lost either through a wound or et cetera. But are there ethical guardrails surgeons typically rely on when asked to alter healthy body parts? And you mentioned this earlier a little bit.
Yes, there is. So at the most foundational principle in aesthetic surgery or cosmetic surgery is that you would never compromise or surrender function for the sake of form, right? So, for example, if a young lady presented to me saying that she would want the appearance of her nose changed, maybe she has an ethnic nose that's bothersome to her somehow. Certainly, rhinoplasty surgery or surgery of the nose is a very common thing. Now, if I was to develop an operation for her to change the appearance of her nose so that she looks decidedly different, take away the hump or whatever it may be, if I knew before that operation started that she was going to lose the ability to breathe through her nose, that would be a highly unethical thing to do because she'd be losing function for the sake of form. So I would never do that. I would never do an operation to improve or change appearance that's going to cause the loss of function in pursuit of a cosmetic outcome.
Hmm. And that's a very important distinction.
You know, the other one I would add to that is that you wouldn't do an operation that's going to is going to in some way compromise the life of the person in an important way. So the example I like to use is that in ancient times, if a woman wanted to color her hair, she would just about have to be Pharaoh's daughter to afford the price of the henna to change the color of her hair. And if she was a woman of average means, raising a family with children and stuff, if she was going to have to take food out of the mouths of her children to accomplish this cosmetic result, that would be a highly unethical thing to offer to the person. Now, these days, you can pick up hair coloring on your way home. And so changing the color of your hair isn't an ethical problem as it would have been in ancient times. But there are comparable circumstances now where you're going to put the patient in the hospital for a while to achieve the result, or you're going to put them into such financial straits to achieve the result, or the length of the anesthesia is going to risk their health. These are all considerations in the pursuit of a cosmetic result. So we have to be very careful about that as well. So.
Right. So let's move on specifically to the issue of sexual identity disorder. When did you first encounter the issue in a clinical or policy context? And was there a particular case that became very personal to you that led you to say, I have to do something about this?
Well, you know, throughout my training, the issue of persons seeking to change their appearance in pursuit of a presentation of the opposite sex, these were very rare and sort of unusual things that you heard about when you were in training. So, for example, when I finished up my general surgery training, I was a staff general surgeon and I was looking around for a place to do my plastic surgery training. It came to my attention that there were a couple of programs. In fact, actually, there was only one really at University of Virginia at the time that included a staff surgeon that was doing what was then called sex change surgery, which of course is not a reality, but we called it sex change surgery. I thought, well, that's peculiar. Some people are actually doing that. You know, it was a rare thing. You didn't really hear about it. You heard about it in the news, you know, about Renee Richards, the ophthalmologist tennis player who had sex change surgery. These were very rare things. And so it didn't enter into my thought particularly. But I heard of the cases and I read about some of the cases, but it was not in the general experience of surgeons, either in training or in practice, to see this particularly. Very, very rare things indeed. But by the time I was out of training and in practice, I started hearing more about it. And I really started hearing about it in the 2005, 2006 range, hearing more about it. But then it really exploded about 2010. Um, and what really came to everyone's attention was that it was coming to us through political channels, and you were hearing about programs that were now offering training in these things. So that was a while back. So for the almost the entirety of my professional life, didn't hear a thing about it. But back in 2014, I was asked to look into it. In fact, I was asked to look into it by the church, believe it or not. It was not a professional motivation that happened, but I was at a conference at Villanova, and it was a breakout session for clergy. I'd only been a deacon for a few months. A breakout session for clergy, and there was a priest there. He was a participant. He was not a presenter or anything like that. But he stood up, went up to the microphone, and essentially offered the opinion that one day the Catholic Church would come to a reasonable understanding of the science, that we would one day accept the science, and that the Catholic Church would one day accept the idea that human sexuality exists on a spectrum. I stood up myself and I offered fraternal correction. And somewhat of a public argument ensued, but as a result of that public conversation, a leader in the church said, Dr. Lappert, because you are a deacon and a doctor, and you understand this somewhat, you should put together a presentation so that we can better form people on this very difficult subject. So that was in 2014. I started giving presentations back then, and so here we are.
Wow. Well, I'm
Mhm.
so glad that you were there to offer that insight and your experience. You have said that surgical interventions on minors with sexual identity disorder raise profound medical and ethical concerns. What are the key concerns from a surgical standpoint? And I know we're going to go through each one of the different surgeries, but just general concerns about any of these types of surgical procedures, especially on minors.
Well, so going back to our earlier discussion, the first thing to understand about these surgical procedures, whether on adults or minors, is that it's cosmetic surgery. So the desire, the motivation for surgery begins in the subjective life of the patient. That there's no objective finding, there's no objective loss, there's no objective uh, poverty that you're going to restore either form or function. So it begins in the subjective life of the patient. It is a cosmetic operation. It is these are cosmetic operations that, by definition, all of them result in permanent functional loss. The person invariably loses a human capacity, whether you're talking about the capacity to breastfeed, the capacity for sexual arousal, the capacity for reproduction. Those things are irretrievably lost. So it fails utterly in terms of the ethics of surgery. It fails utterly in that regard. The other very important thing is that even if you were to imagine that doing such procedures is up to the patient, that it's their right to have these procedures done, a child is not competent to offer consent for surgery. So there's a lack of valid consent. So not only is it an unethical operation, but the consent process is totally invalid, and especially so in the case of a child. I would suggest to you, even in the case of an adult, you hear it said all the time that we must do these operations because they are quote unquote life saving, that if you don't offer gender affirmation care, gender affirmation surgery, that the person is at major risk of harm, self-harm, or suicide. Well, a person who is self-harming, a person who is suicidal, by definition is incompetent to give valid consent. So in every regard, it's ethically unreasonable to even offer the procedure.
Right. And do you have an idea of how many of these surgeries are happening on minors and how many on adults each year? Do you have any idea of how many total surgeries have been done?
This is a very difficult question, Arena, and I looked into it before I gave testimony for the Federal Trade Commission. Between about 2014 and about 2023, it's estimated that there's somewhere in the range of 15,000, give or take,
Mm.
of such procedures done on minors. The problem with that number is that a lot of these procedures are done in private practices, in private surgical centers, or is done otherwise as fee-for-services procedures that are not reported. So these things get reported when public or private insurance is used. But if this is done on a fee-for-services basis in a private institution, it's not being reported. So I would be maybe offering an educated guess, but it's probably somewhere in the high 20s or 30,000
Mm.
involved people over the last 10 years or so. But again, this is just an educated guess. As
And
far
that's
as
for
what's
minors in the US?
correct.
Hmm. What about for adults? Do you have any idea?
Again, so now you're looking at procedures that have been offered for many years, and virtually all of them historically in private facilities. But in more recent times, public insurance is paying for it, private insurance is paying for it. So we're seeing reporting, but the numbers are probably considerably higher, maybe by an order of magnitude larger. So a large cadre of patients.
Wow, it's definitely a lot more than I expected to hear. And as you said, there's probably even more, given that the reporting is probably they're probably underreported. I'd like to now go through some of the different surgeries, and we'll start with the female and the surgeries that a female may get to appear as a male, and talk about the risks, including the developmental, anatomical, functional, and long term outcomes. So, for a woman who wants to appear as a male, one type of surgery is a mastectomy, which is also called a chest or a top surgery, where her breasts are removed. Can you tell us a little bit more about that procedure and some of the risks involved?
The first thing to understand about that procedure is that it's the most commonly done gender affirmation operation offered to children. The reason being that the fastest growing demographic of patients is adolescent to young adult females seeking to present as males. So the operation is euphemistically called chest masculinization. They don't use the term mastectomy, they call it chest masculinization. The
Mm,
operation involves making two incisions on the chest, one in the shadow of both breasts. The two incisions meet nearly in the midline, but the incision is made in the shadow of the breast. The skin is elevated up off the breast, including the nipple. So the
mhm,
nipple and skin are raised up, leaving the breast mound there. The breast mound is then peeled off the front of the chest, peeled off the pectoral muscles and the muscles on the lateral chest. And then the liposuction is often performed around the lateral chest wall to
mhm,
perhaps make the ribs more visible out laterally there. Then the nipple is removed from the breast mound. The nipple is then prepared as a full thickness skin graft. That incision is then closed, so the incision that was under the shadow of the breast is closed. The new position of the nipple is marked out on the chest wall, and that area is prepared to receive the nipple, which is then reapplied as a full thickness skin graft. That
mhm,
nipple is then bolstered in place because skin grafts have to be protected while they take, and then drains are placed to collect any fluid that wants to accumulate underneath that skin flap that you've elevated up in
mhm,
order to expose the breast. Okay, so drains are placed. The drains are typically left in place for about 7 to 10 days. And then what you have left is the complete absence of both breasts. You have scars that extend
mhm,
nearly across the entirety of the chest. And then you have these two nipples that are entirely non-functional. They're not even sensate. They don't have
mhm,
sensation any longer because in doing the operation, you've separated the nipple from its very specialized nerve supply. There's a very special nerve called the fourth intercostal nerve, the branches of which connect to the hypothalamus of the brain. This is a very privileged connection that the body has. And so that stimulation of the nipple stimulates the hypothalamus, which causes the pituitary gland to produce oxytocin. And
mhm,
oxytocin is the hormone that does two things. It stimulates the breast to produce the milk, but it also has a very profound bonding effect between the mother and the baby, or even in the sexual embrace of husband and wife.
mhm.
So that is completely severed. So you have the loss of two human functions, the capacity to breastfeed and the effects of what we call the bonding effects of
Mhm.
stimulation of the breast of the woman, both
Wow.
irretrievably lost.
Wow. It's very jarring to hear about all of this, and we're going to go through each of these. Hysterectomy, of course, is the removal of the uterus. I don't know if you have any comments on that procedure itself.
Sure. So this is a common operation done on young women. A hysterectomy is it's usually done laparoscopically, meaning that a scope is passed into the abdominal cavity, and the uterus and what were called the uterine adnexa, the fallopian tubes, the ovaries, are removed together, essentially castrating the woman. And then oftentimes the vaginal sleeve is removed at the same time. The vagina is obliterated. Those operations are typically done at the same time, partially laparoscopically and partially externally. So it's the complete removal of the reproductive organs.
And then as part of that too, potentially there's the oophorectomy, the removal of the female ovaries as
Correct.
well?
Yeah. Yeah, as I say,
Okay.
that's commonly done at the same time. So the
Mhm.
ovaries are removed, and the uterus and the fallopian tubes typically together, yeah.
Mhm. Now, if a woman wants to go further and construct an artificial penis, that's called phalloplasty. What is involved in that, and as well as a scrotoplasty, which is using the female's labia minora to try to mimic the appearance of a male scrotum.
Well, so a couple steps beforehand. So women who are seeking to present as men are typically on supernormal doses of testosterone, which is a very powerful hormone. It's given in very, very high doses in order to force the woman's body to appear more masculine. And that has numerous effects, including the growth of facial hair, a general increase in muscle mass, certainly an increase in aggressiveness. But among its effects is clitoromegaly. So the clitoris tends to enlarge to varying degrees from one woman to another, and that clitoromegaly is often used as instead of phalloplasty. There's an operation called metoidioplasty, which is essentially turning the hypertrophic clitoris into the appearance of a penis, right?
Mm.
So it involves lengthening of the urethra on the undersurface of the clitoris. The clitoris is embryologic equivalent to the dorsum of the penis. And so metoidioplasty essentially is a very common operation because it's a very common desire of a woman seeking to present as a man to be able to step into a men's bathroom and urinate standing up. This is a very
Mhm.
common subjective desire on the part of women seeking to present as men. So this more common operation involves releasing the ligamentous attachment of the clitoris so that it projects more, and then lengthening the native urethra on the undersurface of this hypertrophic clitoris. That's called metoidioplasty, a more common operation than the phalloplasty. Phalloplasty is a more advanced operation where you're seeking to produce a counterfeit penis using soft tissue from other areas of the body to produce a cylinder of flesh that's then placed uh, at the base of the clitoris. The vagina has been obliterated, and this tissue is transposed onto the pelvis there, and then the urethra is lengthened as part of this construct. So you construct a cylinder of flesh within which is a skin-lined urethra, which is attached to the native urethra, and the whole thing is suspended there at the base of the pelvis with the native clitoris placed at the base of the phallus in the
Mm.
hopes of preserving sexual arousability,
Mhm.
because you've obliterated the vagina, and whatever remnant there is of arousability is what remains in the clitoris. And that itself becomes compromised because this operation I just described to you, in having to either release the ligamentous attachments or place this construct at its base, you compromise the native arousability that they had in the first place. So the labia of the vagina are the embryologic equivalent of the scrotum. So when you obliterate the vagina and you close that skin at the base of this counterfeit phallus, you're creating a counterfeit scrotum, and very often prosthetic testicles are placed in there to further increase the appearance of this thing. So the soft tissue that's used to create this counterfeit penis can come from a variety of places. It can be from the skin of the thigh, it can be lower abdominal skin. More commonly these days, the more advanced operation uses the skin of the forearm and takes
Mm.
that skin completely free, with its blood supply isolated, its nerve supply isolated, and that is formed into a cylinder of flesh within which is the skin lined urethra. And then it's attached to the blood vessels of the groin. The nerves are attached to the nerves of the groin, and you then have this counterfeit phallus. And then often
Mhm.
they'll place prosthetics within that cylinder of flesh uh, to mimic erection and to permit penetrative intercourse.
When they take the skin either from a thigh or the arm, obviously it leaves a big scar. What does that look like? And also, can you talk a little bit about the risks of all of these surgeries, both the short-term risks as well as the long-term outcomes.
Okay. Well, before we talk about the scar of what we refer to in plastic surgery as the donor defect. So if I take skin from your forearm and move it somewhere else on your body, your forearm is going to pay a price for that. That's called the donor defect. Part of the defect is cosmetic, and part of the defect may be functional. But going back to these operations, so beginning then with the metoidioplasty, release of the ligament that attaches the clitoris to permit it to project further. That involves dissection around the nerves of the clitoris, which can compromise sensation in the clitoris, and that can be irretrievably lost. Whenever you do surgery on the urinary tract, things like lengthening a urethra, you're creating a skin tube that has sutures that close the tube. You're taking an open flap of skin
Mhm.
and you're closing it into a tube. So there's a line of sutures wherever it's closed. There's also a line of sutures where you're attaching it to the native urethra. And so you have healing processes involved all along that construct. Wherever you have healing that includes foreign material like sutures, you can get scar issues, and the scars can cause strictures of the urethra that can block the flow of urine. Problems with
Mhm.
healing can cause what we call urinary fistulas, where now you have urine leaking out of the construct in random places, right? And
Mhm.
loss of continence, loss of the ability to control the flow of urine because of the obstruction or because of fistulas or these connections. Likewise, with the phalloplasty, you're now creating a very complex construct with lots of suture lines, not only to create the cylinder of flesh, but also to create the internal urethra that you've constructed in there. So lots of suture lines, lots of sutures, lots of opportunities for wound healing issues that can produce strictures, obstruction, fistulas, or urinary leakage. That can cause further problems, certainly require further surgery, can complicate things with urinary tract infections. And certainly, if you have foreign material in there, like a prosthetic testicle or a prosthesis to permit penetrative intercourse, those prosthetics typically have to be removed in order to manage any infectious
Mhm.
complications that can develop. And whenever you raise flaps of tissue and transpose them or move them to another part of the body, you can have problems with blood flow because you're reconnecting the blood supply, the arteries and the veins. And whenever you have compromised blood flow, you have compromised healing. And that healing problem can be all the way from a trivial chronic wound to a complete loss of the flap, where the flap utterly dies and has to be removed. And so now you have a donor defect and you don't have the counterfeit phallus. And now you have to go to another operative plan just to manage the issues you've created.
Wow. How much of this is actually shared with a patient beforehand? Not only what the procedures entail, but the risks involved. Is there enough informed consent? And obviously, as you said, for a minor, they can't even give informed consent.
Right. In the case of a minor, it is an utterly meaningless thing. And one of the interesting results of the trials involved in the various states, in particular the state of Tennessee and the state of Alabama, where the records of the World Professional Association of Transgender Health, in their own internal conversation about these procedures, particularly in minors, they confess to one another that these patients of theirs, these minors, don't have any idea what they're getting into. Certainly not the long-term effects of hormone therapy, and most certainly not surgeries. So consent in the case of a minor is an utterly meaningless thing. Um, in terms of the consent that the parent gives, though, uh, the parents, particularly when talking to the detransitioners that I've met, and certainly there are a lot of people giving public testimony on these issues now, what they almost universally tell you is that it's a very cursory thing.
Mhm.
It's a very cursory thing, and it's particularly difficult for these patients because what they've been told through the whole process of their affirmation, their social affirmation, their medical affirmation, and so on, is that their only hope is to continue on ahead. And they're constantly being rehearsed with the idea that, well, your child is very likely to kill themselves if you don't move ahead. So the parents come to believe that regardless of how bad it may get, it's better than seeing my child die. And
Mhm.
so the consent is basically consent under duress. which is
Mhm.
also an utterly meaningless legal document at that point, regardless of how exhaustive they may have been in talking about the risk of a fistula or the risk of urinary obstruction or the loss of the flap.
Mhm. Right. And I wanted to now move on to some of the surgeries that a male may get to appear as a female and to talk about what's involved with those surgeries as well as the risks. So, penectomy is the removal of the penis. Can you tell us about that procedure?
Well, historically, these operations were more commonly done in men because the demographic of gender identity disorder was 80% little boys. Of all the children presenting with this, over 80% were boys, most
Right.
of whom would get over it in adolescence or young adulthood. So the very small numbers that would reach adulthood were virtually all men. And the most common operation done in terms of the genital surgery was an operation called inversion phalloplasty, okay, where the skin of the penis would be used to create the counterfeit vagina. So that operation involved essentially filleting the penis open on its underside, shortening the urethra, removing the erectile tissue, the corpora within the phallus, um, preserving the glands as a separate structure on a separate blood supply, and then closing the skin of the penis and inverting it into the pelvis and placing it within the pelvis, having castrated the young man, and the scrotum now is then used to create counterfeit labia, right? So you're going reversible. We talked about before. The scrotal tissue is used to create counterfeit labia, and then the skin of the penis is inverted into the pelvis to serve as the vaginal sleeve. Okay, so historically, that was the most commonly done operation. A portion of the glands would be preserved on its blood supply and placed just above the urethra, which has been shortened. So now you have the shortened urethra, above which is this counterfeit clitoris that you've created out of the glands of the penis.
Mm.
And then that skin inverted up into the pelvis. So again, you have suture lines all over the place where you've closed the skin of the penis to create the sleeve of the counterfeit vagina. And you've placed that up in the pelvis between the bladder and the rectum,
Mm.
right? Now, the skin of the penis is skin that is functionally and microanatomically perfect for life in the outside world. It's not skin that secretes fluids. It's not skin that's mechanically protective in a warm, moist environment, and it's not
Mhm.
skin that wants to maintain its dimensions. So essentially, you've tucked the skin up into an environment that it doesn't belong in, and it wants to
Mm.
collapse down and shrink down to nothing. And so patients who had had that operation historically would have to dilate this counterfeit vagina twice daily just to maintain its dimensions. And so you're mechanically traumatizing this structure that has all these suture lines in it that's placed between the bladder and the rectum. So the very common problems with that operation is, again, fistulas, where you have a wound healing problem, you've got a foreign object like a suture. The fistula develops into the bladder or into the
Mm.
rectum. So now you
Mm.
have urine leaking out of the bladder or feces leaking out of the rectum into this counterfeit vaginal construct, what are called enteroneovaginal fistulas, cystovaginal fistulas requiring repeat operations. So that historically was the most common operation done following penectomy. What is more
Mhm.
commonly done today, for reasons I'll explain, is the use of a segment of colon as the counterfeit vagina. So one of the consequences of the early adoption of gender affirmation in children is the use of puberty blockers. And
Mhm.
one of the very profound effects of puberty blockers is that it causes a poverty of development in the penis of the little boy who's been given these puberty blockers. So by the time they've had a full course of puberty blockers and cross-sex hormones, by the time they present for the genital operation, there isn't enough tissue there to do the phalloplasty operation. So that it requires the use of other flaps. And the most commonly done flaps now are the use of a segment of colon that is
Mhm.
then attached to the outside world, having constructed the counterfeit labia from the scrotum after castrating the young man. So now you have suture lines of colon sutured at the outside of this counterfeit vaginal entryway. And then you have suture lines inside where you've closed the colon internally. That's a more common operation. But as before, it's total mutilation of the genitals, castration. In the case of the male, it's removal of the testicles, the adnexal structures, the vas, and so on. All that's left in place is the prostate gland.
Mhm.
Everything else has been removed. And again, a portion of the glands is preserved at the base, just above the urethra, to simulate a clitoris.
Mhm. And as you mentioned, the removal of male testes is called an orchiectomy. And then
Correct.
in terms of the formation of a vaginal canal, that's called vaginoplasty. Is there
Correct.
anything more involved with that procedure?
So in the first operation, the vaginal canal is created using the skin of the penis. In the case of the second operation, the vaginal canal is created using a length of intestine. And then
Uh-huh.
the opening of the vagina is constructed using the skin partially of the base of the penis as well as the scrotum to create what's called the vaginal introitus, or the entryway into this counterfeit vaginal canal that you've made using a segment of colon.
Mhm. And then if a male wants to imitate having breasts, it's called augmentation mammoplasty. What's involved with constructing female-liked breasts for male?
Well, as in the case of the woman seeking to present as a man, in the case of the man seeking to present as a woman, he's using cross sex or wrong sex hormones in supernormal doses. So men seeking to present as women are typically on very high doses of estrogen, which has effects. That estrogen will cause a condition called gynecomastia, where the patient will develop varying amounts of glandular tissue under their nipple. So they will have some increased volume on the anterior chest. It also increases subcutaneous or under the skin fat. And so they will have some local development, but it's typically not enough, because people seeking to present as the opposite sex, one of the things they always seek to avoid is somebody mistaking them for their natal sex. So they tend to overdo the presentation, just as they tend to overdo the mannerisms, they tend to overdo the clothing, they also tend to overdo the surgical interventions. So they will typically go for an augmentation mammoplasty, which involves the placement of a prosthesis, either saline filled or silicone gel filled implant underneath the nipple to create a breast mound.
Mhm. And with the surgeries involved with the male, what are particular risks, both the short term and long term risks of these different procedures on a male?
So as we talked about before, lots of suture lines, foreign material, areas that need to heal, where healing may be compromised. You can develop those fistulas, which are connections between this structure you've created in the outside world and connection to the internal structures of the bladder and the rectum, causing fistulas. You can also have strictures or obstruction in the shortening of the urethra, where you've sewn the shortened urethra to this vaginal entryway that you've created. You can have urinary strictures that require further surgery. Not as common as in the operations for women seeking to present as men, but common nonetheless. Certainly the fistulas are more common in men seeking to present as women, because this entire construct is placed up in the pelvis, one, where you can't monitor it, and
Mhm.
two, where it's in direct contact with the bladder and the rectum. So fistulas are more common there, and associated infections. So if you have a fistula connecting this counterfeit vagina to your bladder, you can get urinary tract infections as a result of that,
Mhm.
because of the bacteria living in the counterfeit vagina, getting up into the bladder. Whenever
Mhm.
you do operations where you're isolating and moving a segment of colon, you can have problems of the reconnection. So you take out a segment of colon, you have to reconnect, so that you have continuity of the rectum with the outside world. You can have strictures and problems with that as well.
Mhm.
Not as common in these modern days of colon surgery, but possible nonetheless. In the
Mhm.
case of the breast implants, you can have problems of infection around the implant requiring removal of the implant, or what is perhaps more common and result of similar processes is what we call encapsulation, where the implant becomes encapsulated with a sleeve of scar type tissue that causes a painful contraction requiring surgery to relieve the discomfort.
Mhm. Wow. Well, thank you for sharing. And this is very difficult to hear, but I think it's important for our listeners to know what's involved with all of these different procedures. Many people assume that these surgeries are reversible or easily corrected. And from a surgical perspective, are any of these surgeries reversible?
Well, in the case of a man who had sought to present as a woman who is what we call detransitioning or wants to step away from all that, the removal of the breast implants is not a complicated thing. In fact, I've done it for detransitioners in my office. It's a very simple thing to do under anesthesia. You typically go through the existing scar, you take out the implant, you place a drain. Uh, Oftentimes, you have to come back and remove that developed glandular tissue that they developed because of the estrogen they were on. That's called a gynecomastektomy. These are office level procedures, local anesthetic, light conscious sedation, not very complicated. And then you essentially that can restore their male chest. In the case of a woman who has had mastectomy, you cannot replace the breast. You can create a breast mound that looks like a breast. This is an operation very common. I've done hundreds of them for women who have had breast cancer surgery, who've had their breasts removed for the care of breast cancer. You can restore a breast mound, but you cannot restore a breast. You cannot restore the ability to breastfeed. You cannot restore the loss of sensibility in the nipple because you can't reconstruct that fourth intercostal nerve yet. It's
Mhm.
technically possible, but the likelihood of a good outcome is small, and the complexity of the operation is kind of expensive. So you cannot restore the breast. You can only restore the appearance of a breast. As far as the genital surgeries go, it's utter and complete mutilation. You cannot
Mhm.
restore the reproductive capacity. You cannot reverse what you've done as far as a mutilation goes. Now, I have done reconstructive surgery for people whose genitalia have been massively wounded. Combat injuries, IEDs, where you've had massive, devastating wounds, where you have a patient who arrives with a massive loss there, and you reconstruct a phallus so that they can have urinary continuity, perhaps have urinary continence, the ability to urinate standing up again. But I can't restore their loss of sexual function. If they've lost their testicle, you cannot restore that. You
Mhm.
cannot restore the ovaries or the uterus of a woman. People are experimenting with uterine transplantation, but these are these ghoulish doctors who are hoping to do this for people with gender identity disorder, to do a uterine transplant into a male pelvis. A horrific idea and concept, and likely will be a very very horrible outcome as well. But so once you've mutilated the genital, all you can restore is appearance and perhaps urinary continence, urinary continuity, but you cannot restore the sexual function.
Mhm. Wow. And what do you see as the biggest misconceptions the public has about these surgical interventions on people with sexual identity disorder?
The most common misconception people have, they have this idea that when you do a cross sex surgery, you're actually creating a penis, or you're
Mhm.
actually creating a vagina, or you're actually creating a reproductive structure. And certainly when you talk to the detransitioners who went through this in adolescence and things like that, they had these misconceptions. I thought that I was going to have an actual vagina. I thought that I was actually going to be able to be the fullness of a woman. When typically all they have, in the case of a woman seeking to present as a man, is they have a counterfeit penis. It doesn't have the sensation of a penis. Whatever sensation you were able to preserve in the thing is what we call protective sensation. So, in the case of that operation where we take the forearm skin and make a phallus out of it, we bring the nerves and we attach the nerves. The best you can hope for with that operation is what we call protective sensation, that the patient would know if it was being harmed because it got caught in
Mhm.
their zipper or they're sitting on it or something like that. Protective
Mhm.
sensation. because the nerves are hooked up to nerves in the groin. So if they have any sensation in it at all, it feels as if something is touching their groin. It's not the same sensation as a penis would have. It's just protective sensation. And certainly it does have absolutely no reproductive capacity. It doesn't have the capacity for sexual arousal or the results of sexual arousal, ejaculation, or any of those things that people think of when they think of a sexual capacity. When you put the implants in the thing and allow for penetrative intercourse, it's essentially has the dull sensation of lower abdominal contact, and that's it.
Mm-hmm.
So that's probably the most common misconception, is that we're actually creating the genitals of the opposite sex, and we're not. We're creating counterfeits. You're
Mm-hmm.
essentially destroying a human function to create a counterfeit cosmetic outcome.
Mm-hmm.
And I mean, you mentioned for a woman that obviously the sensation is just a protective sensation. Is that true for a male too? A male who's gotten these surgeries to present as a woman, um, does the male also lose most sensation, sexual sensation?
In the case of the male, the sexual arousability that they preserve is whatever was preserved when that portion of the glands with its nerve supply was protected as it was dissected off the penis. You're dissecting
Mm-hmm.
that off the penis and placing it in a new location above the shortened urethra. So whenever you move tissue around, whenever you isolate tissue, isolate its nerve supply and things like that, you compromise sensation. So whatever sensation is preserved in the case of the male seeking to present as a woman is something less than what they had previously. If
Mm-hmm.
you go online and you go to the websites where the podcasts and the blogs and all the rest of that stuff where people talk about their journey of transition, one of the common things you find described there is whatever sexual arousability that they have is some portion of what they had previously. It's been reduced. And typically, what they'll describe is that if they are capable of orgasm, it's something only they are capable of provoking, because it's such a limited thing that
Mm-hmm.
ordinary sexual contact doesn't provoke it enough to result in orgasm. So they typically describe the capacity for orgasm as some process of masturbation that only they seem capable of doing, because it's such a limited thing.
Mm-hmm.
So utterly destructive. Yeah.
Mm-hmm.
And I want to go back to talking about specifically the effect of these types of surgeries on minors. As you mentioned, they usually start on cross sex hormones. And this is something that we talked with Dr. Van Meter in a different episode, all about the cross sex hormones and puberty blockers. But obviously, that stops or slows down the development of their bodies. Why does biological age, bone maturity, endocrine development, brain development matters so much in evaluating whether a minor can consent to surgical interventions?
Well, as Dr. Van Meter already related to you, probably better than I ever could, is the use of puberty blockers, in addition to stunting growth generally, skeletal growth, muscle mass development, the musculoskeletal coordination. It has very profound effects on the brain development, particularly such things as higher executive functioning. So the capacity to make reasoned decisions. First of all, it doesn't typically mature in the case of females until into the very late teens, early 20s, and in the case of males, probably 3 or 4 years beyond that. So the fullness of maturity anyway is typically in the 20s. If you stunted it from about the age of 9, then that has profound effects on their capacity to make an informed decision, the capacity to choose things, the capacity to reason through things, what we call higher executive functioning. In addition to the sexual maturation, just an understanding of what sexuality even is, they haven't experienced any of that because it's been blunted by the puberty blockers. And so when you tell them that they're not going to have the capacity to reproduce, it's a meaningless concept to them. In fact, even the internal conversation of the WPATH doctors uh, shows us this, that even those doctors who give gender affirmation hormones and offer surgery, they recognize that the children don't understand what you're talking to them about because of these effects of the puberty blockers. They don't even know what sexuality means because they
Mhm.
haven't matured at all sexually. They haven't developed the affective maturation of, understanding what the opposite sex even is, right?
Mhm.
Much less making a decision about that in their future. It renders consent utterly meaningless.
Mhm. And are there surgical risks unique to minors that differ from adults undergoing similar procedures?
Well, the general health of minors tends to be better, and anesthetic risk when you're talking about adolescents and young adults is probably comparable. The structures you're working on are often smaller, but the risks that you see in adults are risks that you'll find in adolescents and young adults as well. So nothing
Mhm.
particularly peculiar, other than the fact that, as we talked about, the consent and the risk of the most avoidable complication in plastic surgery, which is disappointment. The most
And
avoidable.
yeah. And with their bodies, since obviously minors and adolescents are not fully grown, if they get these surgeries as a adolescent, do they have to go back and have more surgeries as they grow into their body? Is that something that has to happen, or is that not
Well,
necessary?
these are risks that are not so much associated with their growth as just the passage of time. So the longer you live with, chronic wound because things didn't heal right, the more likely that wound is to degenerate into something bad, especially if you're on high doses of cross-sex hormones. So the longer you live with a breast implants, for example, the more likely you are to encounter the need to revise the breast augmentation. The longer you live with a counterfeit penis, the more likely you are at some point to encounter a stricture that causes urinary obstruction. So it isn't so much
Mhm.
that they're growing, but it's just a longer span of time in which you have wound healing issues, perhaps, or scarification issues where you can present with these other problems. And if you add to that the known risks of high dose sex steroids on the lifetime risk of cancer,
Mhm.
then yeah, the longer they're living with that, the more likely they are to develop a cancer. Particularly so, for example, a person who is on high dose estrogen, right, who has a counterfeit vagina construct, who is mechanically traumatizing that area and has a chronic wound, the likelihood of them developing a malignancy in a chronic
Mhm.
wound goes up very much so in the presence of high dose estrogen, right? So the longer they live with that condition, the more likely you are to encounter a malignancy that's developed there. And we're starting to see reports in the literature of that.
Mm. So you've mentioned that you've operated on detransitioners to restore body parts. What kinds of cases have you seen, and what kinds of cases have you actually operated on?
Well, my experience is very limited with that because this began to develop. I got involved in this issue in kind of the last 6 years of my surgical practice. I closed my surgical practice in 2020. So the only operations I've done reversal wise are the operations related to a man who had sought to present as a woman who had breast augmentation and had been on high dose estrogen. So did the removal of the breast implants and then a subsequent removal of the glandular tissue that developed because of the estrogen treatment. I haven't had to deal with the fistulas because I'm not involved in urology or pelvic surgery. Certainly not since I've retired. So I seem to spend more time referring patients to specialists so that my personal surgical experience is limited to the breast reversal operations.
Mhm. Mhm. And in terms of the surgeries themselves, are there medical challenges specific to these surgeries that are different than the ones compared to standard reconstructive operations that you have done?
Well, so the reconstructive operations for the breast, I've done reconstructive operations for congenital deformities of the breast, Poland syndrome, or or reconstruction following cancer care. So reconstruction of both breasts, including creation of of nipples and that sort of thing. In a patient who has had breast cancer treatment and breast cancer surgery, that's probably a more challenging operation than it is in a young person, a young, adolescent female who is having mastectomy. They tend to be healthier because they haven't had chemo, they haven't had any radiation treatments or anything like that, and so they tend to do better um, than the person who has had those treatments. So as far as reconstruction of the genital area, those are operations where you don't have so much difficulty managing expectation because you have a patient who arrives at treatment with a massive devastating wound. So the patient is fully on board and the defect is fully defined. And so if you encounter complications like urinary stricture because you reconstructed the urethra at some point, the patient is more on board and they recognize that, oh yeah, no, I saw what I looked like before I got here, and I'm totally willing to come back and have a revision on my urethroplasty, or I'm totally ready to do a revision on the vaginoplasty reconstruction because of a stricture or something like that. So the patients are more on board because they're not like the gender affirmation patient who arrived expecting the moon and the stars to be delivered to them, that their life was going to be utterly transformed, and now they're looking at feces coming out of their counterfeit vagina. You're now dealing with a patient who's utterly emotionally crushed by their life experience. Nothing they were expecting is coming true, and now they have this terrible complication. So the alliance between surgeon and patient is much more troubled, and the patient also is typically on a lot of medications, including endocrine support because they were castrated, and now they're on abnormal doses of hormones and being managed by an endocrinologist, and all the other complications that may have come from a history of puberty blockers, a history of wrong sex hormones, and its effects, the metabolic effects of those treatments. So you may have a patient who is obese, metabolically troubled, who's on endocrine support, who you're now dealing with the complications of surgery.
Hmm. When I've spoken with detransitioners, one thing that they expressed was when they were wanting to detransition, they often had to go back to the same doctor who transitioned them to begin with because there aren't that many doctors willing to do that, and obviously that's an awkward situation to be in. Have you heard about that? Are there doctors like yourself who have helped detransitioners? Is there a growing community trying to help detransitioners, or do they generally have to go back to the same doctors who transition them?
Well, I've spoken to a lot of detransitioners, regretters, and a very common thread is that, first of all, they don't want to go back to the doctor who did this to them because they feel as if they were sold a bill of goods, that they had these high expectations of a life transformed for the good, and now they're left in this smoking wreckage, and they don't want to go back to the doctor. The other thing I've heard is that if they do go back to the doctor doesn't want to have anything to do with them. They keep putting them off. Like, yeah, go back and think about it, thinking that the person is emotionally labile now and is not capable of making a good decision, and also fearing malpractice repercussions. They tend to keep the patient at arm's length. So one of the things that we commonly hear is that they have a very hard time finding any doctor at all to take care of them. So there are growing collaborations of doctors, and I can give you some contact information later if you want to post it with this program. Doctors who pool their experience and stuff and share case reports together and offer referrals to particular helps, either surgically or medically. But it's a very common problem that regretters present with, is that they can't find a doctor to help take care of them because all of the specialists who were taking care of them now want nothing to do with them.
Wow. That's a reality for detransitioners. What emotional and psychological themes do you hear over and over again from detransitioners that you've spoken with?
Well, among the common threads are uh, comorbid conditions. So patients very often will have other things going on in their life that was never addressed when they entered into this gender affirmation world. They knew, or they have come to find out, that perhaps they were on the autism spectrum. In fact, it's a 30% likelihood among these patients today that they're somewhere diagnosable as being on the autism spectrum with its associated affective problems, major depression, which was never addressed. I've read clinic notes from detransitioners who have filed suit. I've read their clinic notes, and it's a very common thing that you'll see a diagnosis of depression or anxiety disorder, and the depression and the anxiety disorder is never thought of as the possible cause for their cross-sex self-identification. It's just seen as an impediment that's preventing them from moving on with gender affirmation. So they'll medically manage the anxiety disorder. They'll never get at it psychologically, all with an eye towards removing that as exclusion from gender affirmation. So they'll treat the anxiety not as a cause of gender dysphoria, but as an impediment to treating gender as gender affirmation. You see what I'm saying there? So they'll often report that they were undertreated in terms of their psychological problems. They'll very commonly report actual traumas of childhood, very often sexual traumas that they associated with their dysphoria. And this is a very common thread these days because the most common demographic today is adolescent female seeking to present as male. And what they'll typically report is early exposure to sexual images. The most common age of first presentation to hardcore pornography now is 8.5 years old. So if you have an 8.5-year-old girl looking at hardcore pornography, the last thing she will want is sexual contact because most of it looks like violence against women. The other thing that she'll encounter at school is equally sex-saturated, porn-saturated boys who, when they see her developing secondary sex characteristics, will make a thing out of it. So she will feel unsafe. So they'll often report actual traumas. They'll report exposure to pornography, and they'll report harassment and a feeling of being unsafe because of their femininity. And so they will flee from that. That's a very common thread. And if you have that happening in the life of a young girl who's perhaps on the spectrum somehow, who has a difficult time interpreting people's motives and stuff like that, she will flee from her femininity. So that's a very common thread. But probably most common is a history of some form of trauma, familial trauma, possibly sexual trauma, which goes untreated and unaddressed by the affirmation clinic.
And continues even after they've done these procedures,
Yes,
as you mentioned.
exactly right.
From your experience, do detransitioners often express regret, relief, betrayal once they get to the point of detransitioning? And also, let's talk about those who haven't detransitioned yet. Do you think, from your understanding of the data, are there people who have not transitioned yet who may have regret that they're just not sharing, etc.? What are the emotions? What does the data show about the emotions they have around transitioning and detransitioning?
Well, speaking to regretters, detransitioners, what have you, anger is a common thing. Betrayal is a common emotion. They feel a sense of betrayal. The sorrows associated with what those betrayals resulted in. It's very common that the family dynamic is utterly destroyed by these processes, particularly when you consider how the protective role of the parent gets betrayed by this gender affirmation ideology. The parents are typically recruited into the process by the affirmation clinic with very, very powerful propaganda. And if they don't collaborate, they get referred to child protective services, right? They risk the loss of the custody of their child. So the parents will get recruited into this very damaging series of events. And so when the child or the young person regrets it and wants to go back, now the parents have to live with the fact that they were complicit in this. Even if they thought they were doing the very best thing possible, nonetheless, they signed the consent form. They took the child to the gender affirmation clinic. So now you've utterly destroyed the relationship between parent and child, perhaps irretrievably. Certainly the sorrow that the parents are experiencing now over seeing that all that has resulted in is the mutilation of their child. So sorrow, anger, regret, These are very common things. Uh, in many, there's a sense of relief overlying the the uh, the elements of regret. So you have a young man who was castrated, who is now back to living as a man, who is now matured intellectually, because they're sort of back on track, and they're in those years, and maybe they're getting hormonal support and things like that, and they're coming to understand the nature of the lie they were living, and are actually living a more genuine life. So there is an element of relief, and there's certainly an element of hope, because before it was this wild search for affirmation. Affirmation is not an accidentally chosen word, because affirmation is at the heart of the whole thing. Children feel better if you give them affirming messages. If a child is anxious and distressed and you give them an affirming message, they will feel better. If a child wakes up after with a nightmare, and you go into their room and you give them consoling and affirming messages, they will feel better. Even if you lie to them, a child feels better if the message is affirming, whether it's a lie or not. If you sprinkle pixie dust in their eyes and say, see, this is going to give you sweet dreams, they'll think, oh yeah, I'm going to have sweet dreams. Well, eventually they come to realize, well, that was a lie, but they felt better nonetheless. This is what gender affirmation is all about. You have an anxious child that you're giving an affirming message to. You're promising them that things are going to get better, right? And every time things get rough, it's a new affirmation message. You're going to feel better now, because before you felt better because you let your hair grow out and you wore girls' clothing, but now you're entering puberty, so you feel anxious again. So we've got this new affirming message. We're going to give you puberty blockers, and they'll feel better because they're getting an affirming message, until the puberty blockers prevent their growth, and their peers are now growing and they're not. So now they're anxious again. So you give them a new affirming message. The affirming message is, we're going to give you cross-sex hormones and you'll feel better. And they do. They feel better. They feel better because they're getting an affirming message, and they feel better because they're getting high-dose testosterone or whatever it may be, and they feel better until they don't. And so affirmation makes you feel better, even if you're being lied to. But eventually they come to the realization that it was a lie all along. That's where the anger comes in. That's where the betrayal comes in. But the hope that comes in is that now they're on to the truth. Now they're on to the reality of what their genuine identity, where their genuine identity resides. And it doesn't reside in another person giving them affirming messages. It resides in this internal sense of who they are, who they were created to be, what they're destined to be, and what their true human identity resides in, which is in the sharing of your life with the other, the giving of your life to another, right? The giving of not turning inwards and trying to make yourself better through some identity issue. It's by offering yourself to others around you, in family life, in married life, in your life at work, all of those things where your true human identity resides, in the making the gift of yourself to another person. That's really where it ultimately resides. We are made for the other. Our bodies say that very thing, right? Your genitals don't explain themselves, other than that points to the fact that you were made for somebody else. They don't make any sense unless you recognize that you're made for the other person. So in our very bodies, right? This is John Paul II. Our very bodies scream the fact that we were made for the other person. And that's where the human happiness lies. And so the detransitioners that I meet that are just like crushing it, doing great in life, is that they're living their life for other people. Very often they're living their life trying to dissuade people from going down the road they've gone down, or trying to protect people from going down that road, or giving public witness for what that road looks like. But they're living a very meaningful life now, because it's expressed in love and care and concern for other people.
So beautifully said, and you're totally right. That affirmation of something that is not real, an affirmation of a false identity, is no service to a child or to an adult. You want to affirm reality, not delusion, or encourage a delusion, because ultimately, as you said, it actually hurts them, and not only hurts them psychologically but physically mutilates them. And so they chose the word affirmation very carefully, but
Right.
in doing that, it has harmed a lot of people. So we're grateful for the light that you're shedding on this issue.
You
Yeah.
Thank you, Arena, for bringing that word delusion into it, because we don't want to be afraid of using that word. We want to be careful not to hurt people's feelings. Obviously, you want to be kind to people, but that delusion word is a very important word because this is exactly what's at work here. In us, you can summarize all of gender affirmation, whether you're talking about the social transitioning, certainly the social transitioning, or any of the rest of it, is that you're affirming a delusional idea in the service of an obsessive compulsive process. They're obsessing about their appearance, they're obsessing about their sexuality, they're obsessing about all those things, and they develop these compulsive behaviors of how they dress, how they bind their breasts, how they walk, their story they tell, the language they use, the manners of speech, and things like that. These are all compulsive behaviors that now are being professionally crafted by these gender affirmation doctors. Essentially, gender affirmation is a professionally crafted obsessive compulsive disorder. And obsessive compulsive disorders is not an expression of human health or human identity. It's how we pathologically manage an anxiety that we have never dealt with, a wound. There's an actual wounding event that you have to seek out and help that young person with. You have to find out why they have this terrible thought, what they're hiding from. Essentially, obsessive compulsive processes are a stinking bandage that
Mhm.
the young person, has placed over a wound they don't want to look at. And that's where the care of the wounded, we come back to the
Mhm.
care of the wounded. There's an actual wound there that's being hidden by an obsessive compulsive process.
Right. And as you mentioned earlier, it may be some trauma, maybe sexual trauma they've had earlier, or even a condition like autism that they have never dealt with. And so getting to the root cause of this delusion will help them to actually heal and move forward in a healthy way, in a way that doesn't destroy their bodies. What do you wish that policymakers and clinicians understood about this growing population, not only of those who are detransitioning, but of the transitioners themselves?
Well, w- I think one of the most important things we have to understand, we have to look at how this all suddenly happened. How did this all suddenly happen? How did, like, for example, in the span of my professional life, how did this go from something rare and something I never had direct contact with to something where in my own parochial school, 3 kids in one school year coming up with this stuff? How did this happen? We have to look at the ideologic capture of academia and the result that that had on every professional organization, whether you're talking about lawyers, doctors, teachers, nurses, policymakers, everybody got on board with this ideology. And all of a sudden, right, we have to look at that. The other thing we have to look at is how the imaginative life of children is being sexualized at a very early age, because that is also at the root of it. If a child has a problem and you sexualize that problem, they're going to seek the solution to that problem in sexual matters. If you sexualize their imaginative life, it's not normal for an 8 or 9 year old child to be thinking about things like this in a sexual way unless their imagination has been captured. And that's happening at schools. So policymakers, and unfortunately lately policymakers are getting right into that, but there are places where they haven't yet. But the exposure of children to pornography, the exposure of children to storytelling that sexualizes their imagination is a crime. It is a crime, and it leads to them seeking remedies for their anxieties in sexual ways of acting out, which again, if you capture the imaginative life of a child that's on the autism spectrum or who has experienced a sexual trauma or a physical trauma or whatever, yeah, you're creating the very difficulty, and it largely explains a 5,000% increase in the diagnosis over the span of
Mhm.
3 or 4 years in the last decade.
Mhm. What do you believe that do you think that the medical field is moving too quickly, too ideologically, or without sufficient evidence when it comes to these surgical interventions on people with sexual identity disorder?
Well, this and so much more. So certainly on the topic we've been talking about, the ideological capture of the professional organizations is the problem. It's the problem. My own specialty bought this hook, line, and sinker, although of all the specialties, the Association of Plastic Surgeons never ever endorsed the WPATH, never endorsed the Endocrine Society statement, never endorsed any of those things. In fact, they came out publicly last year and said, hey, wait a minute, we never endorsed this. But nonetheless, they didn't stop it. I went to plastic surgery training days that were exclusively about gender affirmation surgery and how to bring it into your practice. So the ideologic capture of really every professional organization in America, including the Bar Association, the teachers organizations, the nursing societies, all of it. This is the heart of the problem, and we have to get in there and root that out of there because it
Mhm.
does not belong. It does not belong.
Right.
And we've had ideologic capture on other ways, the intrusion of government into all kinds of medical matters lately, that some of them really horrific and historically
Mhm.
terrible have happened. But this is really nothing new. It's happened before. It's happened before, but perhaps this is going to be a very important lesson in how ideologic capture can destroy
Mhm.
ethics in public life.
Right.
Yeah.
What data do we lack, and what long term follow up studies should be required before surgical interventions are permitted? And should they even be permitted for a sexual identity disorder?
Okay, so a discussion of evidence is a very important part of our conversation, Arena. So, evidence is a pretty broad topic, and doctors have been doing things based on their own sense of evidence since Hippocrates. This is nothing new, but what modern medicine has given to us in this conversation is that you can characterize levels of evidence, what is sufficient evidence to offer a form of therapy and what is insufficient evidence. Evidence that's sufficient for an experiment versus evidence that's sufficient for recommending a dangerous intervention, right? So those two things are very different. For example, if I was going to recommend alternatives of cold remedies, that's a relatively trivial thing. And we can base that on my anecdotal experience. Oh, yeah, use Sudafed. No, use Dayquil, whatever. We can rely on my anecdotal experience as a physician and go, yeah, I found that my patients like Sudafed better. Go with that. But when you're talking about a major intervention, like an operation on somebody, particularly an operation that risks function or even risks life, now you have to have a level of evidence that's very, very high. And so now we have ways of characterizing the evidence that allows us to say, yeah, if you were to do this, it would only be an experiment because we don't know what's going to happen
Mhm.
really. Or if you were to do this, they have a 47% likelihood of cure and a 10% likelihood of this complication. That's a very different conversation to have when you're getting consent from a parent about surgery on their child. As far as gender affirmation goes, all of it, all of it from start to finish is experimental in nature, meaning that it relies on anecdotal reporting. It relies on observational data that's limited in terms of how the patients are selected, how the patients are followed. Is there a control cohort? Is there a long-term longitudinal aspect to it? And are there other biases that have to be sorted out? So in plastic surgery, for example, we have a 1 through 5 scale, 1 being the best evidence, 5 being the worst evidence. The worst evidence in support of a clinical decision is a professional opinion, right? So if I, the eminent plastic surgeon, say, oh, yeah, you should do this because in my experience, that's anecdotal evidence. That's level 5 evidence. That's fine if I'm just going to suggest, using Dayquil versus NyQuil, right?
Mhm.
Level 5 is fine, but that's experimental only. Level 4 evidence is if I say, I've done this operation 17 times and I recommend it for you. That's anecdotal reporting, but I now have a case series. It's observational data. I can say I've done 14 cases. I could present those 14 cases, but they were all done by one guy who selected the patients in ways that he hasn't revealed yet, right? And there's no control cohort of patients that he didn't do that to, and there's
Mhm.
no long-term data. So that's what we call level 4 evidence. That's as good as it gets That's as good as it gets in gender affirmation surgery. Certainly that's as good as it gets in puberty blockade. That's as good as it gets in cross-sex hormones for children. It's all experimental. It's all level 4 and level 5 observational data. And here's the real kicker, Arina, is that all of it is quality of life surveys. They do quality of life surveys, all of which is what we call subjective reporting. Do you feel better now since you had your breasts removed and your chest masculinized? Yeah, I feel better. They'll have a quality of life questionnaire that they'll offer this woman, maybe a year after the procedure. So they got a 1-year follow-up on a patient using subjective reporting data. Well, subjective reporting data, again, is the kind of results you get from cosmetic surgery. Essentially, they recognize it's a cosmetic operation, and the only thing they're measuring is subjective results. Are they measuring suicidality? Right? You offered the patient the operation, or you told the parents the patient should have the operation because if you don't, she might commit suicide. They're not even monitoring their patients for suicide rate. They're not following them long term. They're not looking at depression. Have they been have they been hospitalized for drug abuse? Have they been incarcerated for violent crimes? They're not looking at any of the objective data. It's all quality of life surveys. So that again puts it at best level 4 evidence, and it's an experiment. So in order to offer experimental surgery to a child, well, first of all, there better be a life-threatening condition that underlies it. So, for example, when Dr. Blaylock offered surgery on a child with, a blue baby syndrome, and they were going to ligate a structure in their heart, that was an experimental operation. But if you didn't treat the child would die. They had long-term data on these babies with intracardiac shunts. Right? You got to do the operation because here's they got a 90% likelihood of dying by the age of 5, right? Objective data. So it's an experimental operation, but they had a good reason to offer it. In the case of gender affirmation, there is no life-threatening condition. There is none. They don't even have level 3 evidence that gender dysphoria is associated with high suicide rate. In fact, they're admitting that now. They admitted it in the Supreme Court. Chase Strangio admitted it in the Supreme Court that their data supporting the suicide rate of non-transition patients is minimal, right? So you can't even go to the parent and say, well, we have to do this operation or your child will die. So they're offering an experimental operation. Experimental surgery in children, first of all, has to be done under very strenuous control. Experimental surgery in human beings, since the Nuremberg trials, is a very closely monitored thing. But they haven't been doing this with these stringent, monitored human experimentation protocols. They've been doing it in their private offices. They've been doing it in their private clinics. So highly, highly immoral to offer such procedures. So there's no risk of death or harm if you don't do the operation. And there are known harms that we've discussed in horrible detail today together. Those are known harms with no proven benefit. You can't even offer this treatment as experimental. Unethical to do so.
Absolutely. And as you said, it's not only experimental, but you're taking away the function, the sexual function, the reproductive function of children, of males and females, through these interventions.
Grievous and lifelong harms.
Mhm. When you watch mainstream discussions or media portrayals of these surgeries, what do they get wrong?
Well, the media portrayals of it, from start to finish, they get wrong. So, for example, they begin with the idea that there's an airtight diagnosis. Right. Now, in order for me to take a patient to the operating room, I have to have a diagnosis. Like if I'm going to remove their thyroid gland, I have to have a diagnosis that supports removal of the thyroid gland. The diagnosis that precedes surgery in gender affirmation is a diagnosis that's, first of all, the patient is referred to the surgeon often by a social worker. And the social worker will write a letter saying that the patient has met all the criteria for gender affirmation surgery, meaning that they have gender dysphoria and so on. Well, the diagnosis is made by the child. And the diagnosis was typically made by the child in pre-adolescence, right? So you have a pre-adolescent child whose development you've stunted with puberty blockers and affirmation messaging and obsessive compulsive processing, right? So the idea that they arrive at the operating room with an airtight diagnosis is a lie. Even if you accepted the idea that, so let's say 10%, let's say 90% of those patients, 90% of those patients are in fact gender dysphoric and they're going to benefit from the operation. How do you select those patients? There's no selection process. How do you separate them from the 10 who would come back and regret it? You know, the statistics we talked about, let's say the 15,000 people have had this operation. Let's say that 1,500 of them would come back and regret it. Do you want to live with 1,500 people walking around with the regret that so what is the diagnostic process that allows you to separate the good candidates from the bad candidates? There is no such process. There is no such process.
Right.
So no diagnosis. The treatment, the fact that the treatment is presented as life-saving, they'll say life-saving surgery. Gender affirmation is life-saving. There is exactly no evidence that gender affirmation surgery has ever saved anyone's life. Gender affirmation in general, puberty blockers, cross-sex hormones, there is zero evidence that any life has ever been saved by that. All of it is anecdotal reporting. All of it is case series, observational data based in quality of life surveys. Nobody has ever reported long-term suicidality, except in places like Sweden, where they do have long-term data. And the long-term data shows that it has saved no one from suicide. It is, in fact, you see a 40% suicidality rate if you start looking at them out beyond about 8 years. So the long-term data shows us that no one has been given a life-saving treatment by gender affirmation.
Wow. What is the surgeon's duty when a patient asks for a life-altering surgery rooted in psychological distress?
Well, that's a very important question, and as a plastic surgeon, that's where we're sort of in the wheelhouse of this question, because it's a very common thing in plastic surgery to have a patient present to you seeking a cosmetic modification, an aesthetic modification. And when you examine the patient, when you come to examine their motivation for surgery, you discover that the patient thinks that by changing the appearance of her breasts or changing the appearance of her nose, her life is going to be utterly transformed, right? That's called body dysmorphic disorder, which is a subcategory of what we've been discussing throughout this session. Body dysmorphic disorder is where the patient ascribes to their appearance everything that is wrong with their life. Doctor, I know the reason my husband is leaving me is because my breasts are sagging now. And if you were to give me a beautiful breast augmentation, then my marriage will be saved. Or if you were to change the appearance of my nose, women would be interested in me and I would probably get a promotion at work. When you're hearing things like that in the consultation, you're dealing with body dysmorphic disorder. And in that case, regardless of how seemingly trivial the operation is, it's an unethical thing to affirm that false message. You're looking at an obsessive compulsive process. They're obsessing about their appearance, the appearance of their nose rather than their genitals. It's the same process. They're obsessing about that, and they're doing compulsive behaviors like constantly checking themselves in the mirror to see if they've applied their makeup to hide the appearance of their whatever it is. For you to do an operation offering the patient resolution of their anxiety by doing even a trivial operation is unethical. You're taking their money, right? It's snake oil salesman. That's what you are. You're not a doctor. You're a charlatan. It's the same process, whether it's a trivial operation or genital mutilation. It's the same thing, obviously differing by degrees of severity, but same unethical behavior.
Right. And those doctors who are participating in this should have ramifications, right? Their
Yes.
licenses taken away, maybe lawsuits against these doctors, especially as more of these detransitioners are coming out and sharing their regret and even the harms that have been done to their bodies. Have you ever felt professional pressure to endorse or stay silent on surgical interventions on people with sexual identity disorder?
Well, I have the great benefit of not having grown up in that world, but I talk to doctors now who are coming through their residence. In fact, I've been corresponding with a physician, very eminently trained physician who is finishing up her plastic surgery residency, who's been compelled to assist in operations like this, even though morally she's recognizing the
Mm-hmm.
harms that have been done. I've been blessed not to grow up in that era. So by the time the topic came up, I mean, threatening me with loss of my credentials, yeah, okay, fine, I'll retire 2 years earlier. It hasn't been a problem for me, no.
Hmm.
Yeah.
And as a follow up question, what gives you the courage to speak publicly on this issue, even though it's been so polarized?
Well, courage is perhaps a gift. I've had to, you know, protect and defend people who are in danger of harm, and I don't see it so much as courage as duty. For me, it's been more duty than courage. I have never really felt threatened. I mean, I have to go up against ACLU lawyers who can be unbelievably annoying people as far as how they question you, the aggression with which they question you. But I've been questioned by aggressive drill instructors, and so ACLU lawyers don't really scare me all that much. Yeah, so it's more a matter of duty than courage.
Hmm. And you have testified in multiple states about these issues. What insights have come from those hearings that the public should know about?
Well, I think what the discovery processes for these cases has shown is the level of misrepresentation of what's going on to these young people. When you get to read through the medical records, because the complainants are actual patients or the parents of patients who had this done, and you're reading through their medical record, what you see is the massive misrepresentation of diagnostic codes, procedure codes, right? These are actual crimes, right? These are frauds. They're frauds being committed against the families, the patients, frauds being committed against insurance companies, public and private. There's actual fraud going on. The words that they're using to misrepresent the conditions of the patient, that fraud is coming out in courts of law now. It's certainly the Federal Trade Commission is on it. The Justice Department is on it. They're subpoenaing records from gender affirmation clinics, and gender affirmation clinics are closing up left and right. You know, when a very successful gender affirmation clinic in California just suddenly shuts down, which happened recently, uh, something's going on, because that gender affirmation clinic was operating in a very protected environment. The government's very protected. What it's telling me is that the discovery is coming to the attention of the lawyers who have been defending these people, coming to the attention of the insurance companies that have been protecting these people, and they're losing their insurance, their professional insurance, the malpractice insurance, the indemnity insurance that the hospitals have. All that stuff is evaporating because of the fraud that's being discovered in the medical records, because of these cases that are being brought forth, both in public, in state and federal cases, as well as in many tort cases that are going through the courts now, particularly in places like California, where a very large medical corporation is being sued by a very precious detransitioner who's got fire in her belly and she's going after those people. So that's what's coming out. The fraud is coming to light, and the institutions are waking up to the fact.
Mhm. Wow. So, what questions should legislators ask but are not asking?
Well, that evidence question, because when we were setting about crafting the law here in Alabama to protect children from gender affirmation care, I was really appalled at how uninformed legislators are on the actual level of scientific evidence. Because what they're hearing is, they'll hear some physician group in your capital city that has a big medical center that's doing gender affirmation. Physician group will make the rounds of the legislators' offices and say, look, we have the World Professional Association of Transgender Health, and all of the professional societies are on board with this, and every doctor who's worth his salt is on board with this. Why are you letting these crackpot doctors craft this law that's going to stop all of this stuff? So the legislators have been bulldogged into this idea that there's airtight scientific evidence and that there is universal consensus, neither of which is true. neither of which is true. And when you embrace that fact, everything else falls into place. Whether you're talking about what's being taught in your medical school or what's being taught in your law school, right? All of that is based on this idea that there's airtight evidence and that there is consensus, neither of which is true.
Mm-hmm. Well, what would be a truly ethical, evidence based framework for treating minors or adults with sexual identity disorder, in your opinion?
The first thing is to recognize that this is a disturbance in the subjective emotional life of the patient, that is not a medical surgical condition, and that this disturbance is a real thing. You have to recognize the fact that people are actually suffering and they deserve our help and support. So don't exclude them as crackpots or misguided people that just need to be educated. Remember that there's a wound, there's some sort of a wounding event that's happened in the life of that person that needs to be explored. Historically, the treatment of gender identity disorder was very successful. It's like above 92% success rate in a very small population of patients. And the success happened because of the cognitive, behavioral, family therapy, play therapy, support them with the truth, never abandon the truth, right? That has proven that's a historic remedy. That's why we got 92% resolution rate. And it was just a very small cadre of mostly men who persisted into adulthood, right? So I think and then also removing the harms that are causing these problems, the things we talked about, protecting the child from pornography, protecting the child from sexualization of their imaginative life, protecting their child from these ideologies that draw them into these false hopes.
Mm-hmm. Beautifully said. How does your understanding of the human person, the integration of body and soul, inform the way you view these surgeries?
Well, when I embarked on my life as a physician and then ultimately as a surgeon, I was an atheist and I was not a philosopher, but I sort of intuited that in fact, when I was thinking about going into psychiatry before I even went into medicine, I thought what I want to work on is psychosomatic medicine, because I recognized even when I was just an undergraduate that there's this very important link with what the body is doing and what we're thinking and feeling. Why? Because it's a unity. It's a human nature. What I've come to understand is that this is not a new idea. That Aristotle was speaking about the hylomorphic nature of the human person, that we don't have a psychological soul nature and then a body nature that are intertwined somehow. Those two things together comprise a single human nature. That your body is as much you as your spirit, your soul is you, that the two of them together is your single human nature, and that the separation of those things has a medical diagnosis. It's called death, right? That those two things belong together intimately, the form and the matter and all of it, right? So I've come to understand it philosophically, but more importantly, I've come to understand it through revealed truth. To me, I've come to understand the meaning of the incarnation, that we are an incarnate realities, right? And that the perfect example of the human person is the person of Jesus Christ. That if you separate those things in Jesus Christ, then his salvific work has no meaning, right? Which I think is really the target of this diabolical gender affirmation thing, is this attack on the revealed truth of the incarnation of God in Jesus Christ. So it's taken on a much more profound meaning for it. In my day-to-day contact with patients, we don't go to those depths. We just go to the reality that your body is you as surely as, and the only way I have of knowing you is the fact that there's this body before me. Everything I know about you is because there's this body that's revealing you to me. And so any treatment that purports to say, or any view of the human person that separates those things, is in one form or another a kind of Gnosticism. That the spirit is good, but the body is flawed, and that your freedom comes in recognizing that. This is not a new heresy. The idea that the body is a terrible thing that's holding you back, that's Gnosticism. And that's what we're
Mhm.
telling children, is that the real you is not what you see in your body. The real you is this thing that's being imprisoned in your body, and we're going to set you free. That's Gnosticism. That's a
Mhm.
heresy that goes back about 1700 years or more, right? That's why we need good Dominicans around us all the time.
That's right. And I'm Dominican trained actually, but I would also say with my philosophy background, I blame a lot of this on Rene Descartes, right? I think therefore I am separating the mind and the body as if there's two entities that are not intricately linked, that you can somehow think outside of the constructs, the constraint of your own physicality. So I want to bring it back around to the question of, do you think that modern culture has lost a sense of what the body means?
In every way, the degeneration of the medical sciences into this mechanistic idea, this idea that the human person is the result of a long string of accidental events, that the meaning of the body is no meaning at all because it came about by a series of accidents, that there is no such thing as objective truth, that there's no such thing as objective beauty or goodness. These are all part and parcel with this modern view of the human person that has utterly degraded the practice of medicine and into this very mechanistic utilitarian thing where, we look at the body as this thing that we have rather than who we are. We think of the body as something that we have and that it's available to us to modify in any way we want with the purpose of producing our own happiness, which is the only thing that ultimately matters because everything else is utterly meaningless. The search for meaning in that's the most nihilistic, horrible thing possible. But it's
Mhm.
what's being sold in the world of medicine now. That the
Mhm.
only meaning is, are you comfortable? Are you happy? Right? Suffering has no longer any meaning. It's just an impediment to your happiness. So suffering has to be done away with. Right? I'm all about relieving suffering, by the way. I'm not just discounting that, but I'm saying that in the care of the wounded person, this is one of the things that I encountered in the care of the wounded person, is that my greatest service to them is helping them to recognize that their suffering has tremendous meaning, that their suffering is temporary, but their suffering has tremendous meaning. And probably the only really meaningful thing I did to my patients, apart from surgery and things like that, is to help them recognize that while they're suffering, if they pray for the good of others, that it has profound, profound
Mhm.
meaning, right? It
Mhm.
has profound, profound value, that their value has to. And even before even before my conversion, I had this conversation with more than one woman who comes to me with a diagnosis of breast cancer. I would tell them, listen, your family's going to gather around you to try to console you with your diagnosis of breast cancer. But what you're going to find as you go through this treatment, as you go through all this suffering that you're going to encounter, is that you're going to be a beacon to them
Mm.
about how to deal with suffering, and they're going to benefit from your suffering. Your families can grow stronger. Your children can grow stronger by seeing how you deal with this suffering. So even before I knew who God is, I
Mhm.
recognized that as a reality.
That's beautiful. So what do you think that people are actually searching for when they seek these types of surgical interventions?
They're seeking for happiness. They're seeking for happiness. They're seeking to understand their place in the world. They're seeking to understand why they feel so bad inside, why they're sorrowing inside. They're wanting an explanation for their sorrow, and they want to be happy. And that's generally the human condition. Whether you're talking about affirmation surgery or a shot of whiskey, you're trying to resolve a sorrow. You're seeking happiness, and that can only be found, of course, in the truth. That no one is served in their flourishing by a lie. So they're searching for the truth. They're searching for the truth of themselves, the truth of the hurts that they've experienced, the truth of the good that they're seeking. They're searching for the truth, and the truth is a person. The truth has a name, as it happens. Yeah, the truth has a name, and so that's what everybody's searching for. and by degrees, it's our obligation to help them in
Mhm.
that regard. So that's why you can never ever think that you're helping somebody by turning them away from the truth towards a lie, because they'll never find their happiness there. Because the truth of their life is the truth of why they're here, right? Where they're headed, right? What must I do to prepare for where I'm going, right? Those are the truths of life that have actually have meaning. Why am I here? Where am I headed? How can I prepare for where I'm headed? Right?
Mhm.
That's where happiness lies, and everybody's looking for that happiness. Sadly, though, they're being detoured by all kinds of distractions
Mhm.
in this life that we live. But that's our obligation.
Right,
If we
and they're probably also seeking the healing from the
Yes.
trauma that they experienced, healing from whatever it was that set them on this path. And obviously, we require that we give them the immense compassion, right? Immense compassion, immense empathy, immense understanding for what they're going through. And I think that that's an aspect that is not covered as much. But obviously, the reason that you wouldn't want to do surgeries like this on a patient who wants to transition is because of your deep desire to not harm them, deep compassion you have for them. Is that correct?
Oh, absolutely. Yeah. Do no harm.
Yes.
Primum non nocere.
Um, what do you think the medical field will look like in 10 to 20 years from now with regard to treatment for sexual identity disorder?
Well, there'll probably be a lot of historical hand wringing. There'll probably be lectures about it, like I used to get lectures about frontal lobotomies or thalidomide or what have you. There'll probably be lectures in medical school about the great scandal that was gender affirmation surgery. Um, yeah, so that'll change. Will the human condition have fundamentally changed? No. I mean, we're already moving in the direction of the procured human lives through reproductive technologies, assisted reproductive technologies, artificial wombs. The buying and selling of humanity
Mhm.
is kind of where we're headed unless we stop. So there'll probably be some other scandal. Hopefully, it'll be a minor scandal, a stupid oversight rather than a deliberate evil like I
Mhm.
just described. But the underlying, broken humanity has to be guarded against all the time. That's why
Mhm.
confession is such an important thing. You got to examine what you're doing every day, especially if you're a surgeon. You got to examine what your plan is, why you're doing things the way you're doing them, and have you failed in what you've been doing. Self-examination, a very important part of it. Medical industry hasn't been examining itself at all lately. It's been making a
Mhm.
lot of money, and harming a lot of people. Uh, and so yeah, self-examination. Perhaps we'll do better in the future. I certainly pray that we do. But I have a feeling that gender affirmation will be a relic of the past, that will be the subject of lectures in medical schools, the subject of ethics discussions, in bioethics classes, because there's certainly a lot to be learned here about how the academia can be so utterly captured by an ideology.
Mhm. And as you said, obviously the medical profession's um, duty is to first do no harm, and this is quite the opposite. So we hope that that change will happen within the medical communities and even the academic communities. Do you foresee a large wave of detransitioners needing restorative surgery?
That wave is upon us. That wave is upon us.
Mhm.
Because the huge surge happened about 8 to 10 years ago. The surge has continued, but it began about 8 to 10 years ago, and so the numbers of cases of young people, young adults presenting with these problems and seeking remedy is all that wave is upon us.
Mhm.
Uh, mm,
If you could speak directly to parents who feel pressured into consenting to surgical interventions for their child, what would you tell them?
I would tell them resist the pressure, step away, walk out of the consultation room, walk out of the clinic, get in your car, take your child home. And I would recommend that even if all that's being suggested is cross sex dressing and mannerisms and name changes and pronouns, because remember, that's where it all begins. It all begins with this professionally crafted obsessive thinking and the compulsive behaviors that they develop for your child. Resist all of it. Turn away from all of it. Take away your child's digital device. Separate them from that. Spend more time with your child. Spend more time, constructively, doing direct things outside. Get the child outside. Get the child away from their laptop. Get them out into the world. Get them involved in things where they're thinking about other people, thinking about helping other people, even if it's their little sister or their friend or the charity down the street. Get them outside of themselves and get them out into the world and keep them in contact with the truth. But do not sign any consent form for any of this stuff, even social affirmation. It is poison.
Mm-hmm. Right, absolutely. What gives you hope in this work?
Hope?
Hope.
Hope is a theological virtue, So God gives me hope. It's a gift of God. I don't lay up my hope in the princes of this world, but I lay up hope in the love that God has for us all, and I hope that we can all kind of work together to help people who are suffering. That's where my hope lies. Is that in working together out of love of neighbor and as an expression of our love of God, working together. I have great hope in that. Yeah, if our work is rooted in the virtue of hope, then but I'm not very optimistic. Right? Optimism is a fool's sort of take on it. I'm not optimistic, but I have great hope.
Mm-hmm. Mm-hmm. And finally, what message would you want people to take away from this conversation today?
That hope. One thing I want people to take away from this that I reiterate most anytime I present in public is that you should have confidence in common sense. You should have confidence in your common sense. Your common sense has been you've come to resist your own common sense by this absolute wave of propaganda that's shaming you into silence, right? So do not let them shame you into silence. Have confidence in this common sense thing that a child cannot be born in the wrong body, that a child who has a Y chromosome in every somatic cell of their body cannot be a girl, is a boy. Even a child can identify boys from girls, whether you're talking about, I mean, 99.98% positive test correct that a child can identify the sex of a boy or a girl, right? So that's a reality, and that's a common sense. So and resist these presenting all kinds of idiotic ideas to you.
Well, thank you so much, Dr. Lappert, for sharing your experience and your expertise with us. We greatly appreciate all that you have done and all you continue to do to bring the truth about this matter to the public. So thank you.
Thank you, Arina, for your kind invitation. I've really enjoyed our conversation, and I hope we meet again.
For my conversation with Dr. Patrick Lappert, a twice board-certified plastic and reconstructive surgeon who spent over 30 years in the operating room, here are 7 takeaways about the dangers of surgical procedures on people with sexual identity disorder. 1. Transgender surgeries are not reconstructive surgeries. Reconstructive surgery restores something that was lost, such as regaining function from a physical injury. But transgender surgeries destroy healthy organs, resulting in the permanent loss of organ function. 2. No surgery that sacrifices organ function for appearance is ethical. In plastic surgery, there's a foundational rule. You never surrender function for form. If an operation improves appearance but destroys a human capacity, such as breathing, reproduction, or bonding, it's unethical. 3. In a breast removal surgery, the breasts are gone, and so is the nerve that connects the breast to the brain. A woman doesn't just lose the ability to breastfeed ever again, she also loses the hormonal and bonding pathways that would connect her to her child. That loss is irreversible. 4. These surgeries are irreversible mutilation. Once you remove reproductive organs, once you destroy genital structures, you cannot restore them. You can recreate the appearance, but you cannot restore function, fertility, or sexual integrity. That is permanent. 5. Minors cannot truly give consent because their brains and decision-making capacities are not developed enough to consent to permanent, irreversible surgeries with lifelong consequences to their body and fertility. 6. Parents are pressured into consent under fear. They are told, if you don't do this, your child will kill himself or herself. That's not informed consent. That's consent under duress. And legally and ethically, that's invalid. 7. These surgeries do not create new sex organs, but counterfeits, structures with limited sensation, no reproductive capacity, and high complication rates. Because truth matters and human dignity isn't optional. This is Bioethics Babe. Thanks so much for listening to this episode of the Bioethics Babe podcast. If you've enjoyed this content, please subscribe to my YouTube channel and your favorite podcast platform, and share with your friends and family. Also check out bioethicsbabe.com for the latest episodes and resources.